In the last module of the BPD program, we will discuss the prognosis, long-term complications, and permanent sequelae of BPD. The learning goals for this module are to learn the long-term outcomes of BPD from three main aspects: neurodevelopmental outcomes, health-related quality of life, and pulmonary outcomes. Long-term neurodevelopmental disability is a major concern for the preterm population. Current studies have suggested that BPD is a major and independent risk factor for neurodevelopmental disability in the extremely low birth weight infants. In the trial of indomethacin prophylaxis in preterms, Schmidt et al. Found that three common neonatal morbidities, that is, brain injury, severe ROP, and BPD, strongly predicts the risk of later death or neurosensory impairment in preterm infants born at less than 1,000 grams. As shown in this graph, infants with any one of these three morbidities had a higher than baseline neurodevelopmental impairment at 18 to 24 months. In addition, they have an additive effect with the probability of neurodevelopmental impairment about 90% if all three morbidities are present. Then in the caffeine for prematurity trial, they found this still holds true to predict late death or survival with disability at 5 years. In this cohort, the risk of poor outcome doubled in infants with BPD. Other studies have examined neurodevelopmental issues in the patients with BPD. Beginning with the top figure, Caragiani et al. Assessed neuromotor development using the Hammersmith Infant Neurological Examination in 219 infants born at less than 32 weeks gestation with birth weight less than 1,500 grams. Infants with severe BPD had lower global HINE scores at 6 months and 12 months, corrected age. After adjustment for confounding factors, scores of infants with severe BPD were reduced by 13.2 units, whereas scores for those with periventricular leukomalacia were reduced by 11.1 units at 6 months corrected age. At 12 months corrected age, scores for those with periventricular leukomalacia were reduced by 11.9 units, but severe BPD did not seem to influence the global score. This study suggests that although BPD constitutes a major cause of poor neuromotor outcomes at 6 months corrected age, improvement in motor outcomes can occur over time in these infants. Another study looked at cognitive and academic performance at 8 years of age. VLBW infants were significantly more likely than term children to have full-scale IQ in the sub-average category. Even higher proportion of BPD children, about 20%, had IQ score less than 70 in the mental retardation range, as compared to VLBW infants without BPD. In addition, the BPD group were more likely to be enrolled in special education classes than VLBW or term children. When birth weight and neurologic complications was controlled, BPD and severity of BPD were associated with lower performance and full-scale IQ, poorer perceptual organization, attention, and motor skills, as well as lower school achievement and greater participation in special education, including occupational, physical, and speech-language therapies. Infants with BPD have significant abnormality in pulmonary function in the neonatal period and infancy. Longitudinal assessments of lung function suggest that lung compliance and function residual capacity improve with increasing age and might be normal by 2 years of age. Total lung capacity usually also improves with age. However, many infants with BPD continue to have increased residual volume to total lung capacity ratio, suggesting persistent air trapping. Airflow limitation in FEV1 and forced mid-expiratory flow of vital capacity is a persistent problem in this population, and some data suggests that this can get worse over time. In addition, impairment in diffusion capacity can also persist till adulthood in these patients. In this study, 28 ELBW infants with BPD born in the post-surfactant era were compared to 20 matched preterms and 27 term controls. ELB infants showed a significant airflow limitation, which is particularly pronounced in BPD subjects. In addition, the BPD infants presented an abnormal airway growth trajectory with a decline in lung function between the ages of 8 and 12. In another study, 18 to 27-year-old VLBW with or without BPD were compared to term control groups matched for gender, age, and birth hospital. Lung function was expressed as Z-scores according to the Global Lung Function Initiative standards. Although Z-score for forced expiratory volume in 1 second, forced expiratory volume in 1 second to forced vital capacity ratio, and forced expiratory flow were all lower in VLBW infants as compared to term controls. These abnormalities were more significant in VLBW infants with BPD. Maternal smoking in pregnancy predicted poor airflow in all groups, and this finding was strongest in the BPD VLBW group. Lung structure changes has been identified in survivors of preterm births with BPD. Radiographic improvements in lung parenchyma disease are usually seen over time in these infants. However, many patients have persistent lung hyperinflation, as you can see in this patient at 3 years of age. Emphysema has been reported to be common among young adult survivors of moderate to severe BPD, raising the concern that children diagnosed with BPD are potentially at risk for developing COPD later in life. A number of studies have reported persistent clinical respiratory morbidity of infants, children, adolescents, and adult survivors of BPD. Preterm infants diagnosed with BPD require hospital readmission for respiratory reasons during early childhood at approximately twice the rate of similar premature infants without BPD. Although the rehospitalization rate declined after the second and third year of life, persistent respiratory symptoms, including coughing, wheezing, dyspnea, exercise intolerance, are more common among children and adult survivors diagnosed with BPD during infancy. It is important to note that persistent abnormalities in pulmonary function and respiratory symptoms in BPD survivors may not translate into decreased health-related quality of life measures. A recent study compared 27 adolescents with BPD with 27 asthmatic patients and 27 health controls. Although adolescents with BPD have lower lung function, the BPD group did not differ significantly from the healthy controls in any scale of dimension of the short-form 36 questionnaire, a questionnaire that assessed health-related quality of life measures. Asthmatic adolescents scored lower than those of both healthy controls and patients with BPD in several dimensions, despite having better lung function than adolescents with BPD. No correlation emerged between lung function and health-related quality of life scores in BPD subjects. This concludes Module 7 and the BPD program.
We would like to acknowledge the American Academy of Pediatrics, the Organization of Neonatology Training Program Directors, Neo Reviews, and Abbott Nutrition for their support of this educational program. This concludes this module.